Psoriasis is a chronic, currently incurable, predominantly skin disease, which is inflammatory in nature. It occurs in about 2% of the population of the UK and at least 60 million people around the world. It's associated with a number of important medical conditions, such as psoriatic arthritis, obesity, depression and anxiety, and heart disease, amongst other conditions. So managing psoriasis is not purely managing the skin, and it causes individuals who suffer from it significant psychosocial distress and causes huge cost to both the individual and society. There are a number of different forms of psoriasis. The classic one is so-called chronic plaque psoriasis or psoriasis vulgaris, which is the textbook example and occurs in about 85% of cases. Presents as red, heavily scaled patches on the scalp, the outer aspects of the elbows and knees and the lower back, but any part of the skin surface may be involved. Other rarer forms include flexural psoriasis, or which occurs in the folds of the skin, under the arms, under the breasts, in the groins. Seborrheic psoriasis, which occurs in the eyebrows and the sides of the nose and in the beard area in men and over the front of the chest. Guttate psoriasis is a sudden onset of small psoriasis lesions, predominantly on the trunk and occasionally on the face, occurring after a recent sore throat or tonsillitis. And interestingly, those cases, in about 50% of the time, are self-limiting, but some may develop into chronic plaque psoriasis. And then there are rarer forms which are currently called psoriasis, which are pustular, generalized pustular psoriasis, where sudden onset of painful red skin with little yellow pus-filled spots, which is associated with being systemically unwell. So people have a high temperature and just feel unwell. And that's sometimes associated with ordinary psoriasis. And then palmoplantar pustular psoriasis, where there are little yellow pustules, sterile pustules on the palms and soles, which occurs predominantly in middle-aged women who are or have been smokers. The age of onset of psoriasis is usually before the age of 35. About 75% of people develop psoriasis before that age. It occurs, of course, in children, and 10% of cases occur before the age of 10. And it occurs, the classic time to occur is probably around the age of the early 20s, usually earlier in women than men. But then there's a second late phase of psoriasis, or called late onset psoriasis, occurring in the mid-50s to early 60s. And this accounts for about 20 to 25% of cases. Clinically, it looks very similar, but we now know from genetics and immunology that it may be a different disease. In the Far East Asia, it appears that this form of psoriasis, late onset, may be more common than the early onset disease. Now, psoriasis can occur, different forms can occur together. So classically, a patient with chronic plaque psoriasis may have inverse psoriasis, where it is in the flexures as well as on the body. And the flexural disease can be distinguished from the chronic plaque disease because in the flexures, where it's moist, the scales are not always evident and the skin may look red and shiny. And patients who have chronic plaque psoriasis can suddenly develop a flare of the disease, guttate disease, if they have a streptococcal sore throat or tonsillitis. And then patients also have nail psoriasis as well. About 50% of patients with psoriasis also have involvement of the nails. There's a huge amount of research, and that has led over the years to the understanding of the disease, which has advanced our care of the disease. So we're trying to understand the genetics of psoriasis, why some people get the disease and others don't. And actually that research has already allowed us to show that pustular psoriasis is a different disease than chronic plaque psoriasis. We have a great understanding now of the immunology of psoriasis, which has led to transformational changes for the management of people with severe psoriasis, that we've been able to develop targeted biologic therapies for the condition. But there's a lot of work ongoing. In the United Kingdom, we're particularly interested in what's called stratified medicine. So can we use information on a patient, such as clinical, genetic, and immunological, to allow us to then be able to predict which drug or which treatment is going to work best in that individual, rather than it being a trial and error approach. And we're also learning that lifestyle changes make a difference as well. So losing weight in conjunction with these very good treatments makes a huge difference, as does stopping smoking and also reducing or stopping alcohol consumption. With the development of biologic therapies, we need to understand the long-term safety of these. And also from the UK, we run the British Association of Dermatologists, Biologics and Immunomodulators Register, which is tracking the safety of these biologic therapies over the long term. I'm pleased that the Psoriasis Association has been very closely involved in both the stratified medicine approaches and are also working with us on the British Association of Dermatologists Register. And finally, of course, psoriasis is a global disease. It occurs across the globe, and we really don't understand very much about the true burden of psoriasis in many countries. In fact, we know from recent studies that it affects at least 60 million people worldwide, and probably that's an underestimate. And we know good information for only about 1 in 5 countries around the world. So there's a lot of work to be done, but our goal is that by understanding how common it is, understanding the unmet need and the burden of disease, we can then ensure that any person who has psoriasis, wherever they live around the world, has access to the best care that's available locally.